So as I've done with all of the talks in the past in this conference, I'm going to start off by paying a small tribute to my teacher, Professor Sayan Basu, who very tragically passed away very recently, much before this time. And a big part of the reason that I'm standing here before all of you is him, and he was a great teacher, and I was very fortunate to be his resident here in Kolkata. So I do not have any financial interest to disclose. I'm going to talk about a few products, a few prosthesis implants. And we are basically talking about patients like these who have sustained very severe injuries, chemical burns, and we have done everything possible during the acute phase to save the eye. We have managed to save the eye, but unfortunately now we are left with some of the sequelae of the burn, and we are attempting to visually rehabilitate them. So these are mostly patients with bilateral liver stem cell deficiency, and usually may have some adnexal damage as well. Now, if you have a patient who has a loss of vision because of normal loss of corneal clarity, you can try a keratoplasty. If there is a high risk of failure of keratoplasty in such patients, and if it's a bilateral pathology or the only eye with visual potential, then you can try a keratoprosthesis. And I'm going to talk about case selection a bit more later on. If you have a wet ocular surface and you're talking about non-autoimmune pathologies like ocular burns and patients in whom there is proper lid apposition and closure and deep phrenesis, then we are essentially going to talk about the Boston type 1 devices. Whereas if you have more severe cases where there is a dry surface or autoimmune pathologies or more complicated adnexal damage, then you're going to talk about, then you're going to consider more advanced prosthesis like the Boston type 2 or the OKP or the MQP. So who needs a keratoprosthesis? Like I've said before, somebody with a form of corneal blindness which cannot be corrected with keratoplasty because keratoplasty has very poor prognosis. A good example of that is limbal stem cell deficiency post-ocular burns. Okay. There are a number of ways, and Ikeda alluded to this a little bit earlier. There are alternate ways of addressing bilateral limbal stem cell deficiency. You can do something like allografts, you can do cultivated oral mucosal epithelial transplantation, and you can also do keratoplasties. And we have done plentiful of all of these over the last 10 years. And I'll just show you a graph which tells you which works best. So if you compare connective allografts versus cultivated allogenic limbal epithelial transplantation versus cultivated oral mucosal epithelial transplantation and keratoprosthesis, you can see that the difference is very apparent. You get best visual acuity and the fastest recovery of visual acuity, and the duration for which it stays is also significantly more in keratoprosthesis versus all other forms of cell-based restoration. One overgeneralization that we do is when we talk of K-pros, we just say keratoprosthesis, but keratoprosthesis can mean a lot of things, and these are just examples of different types of keratoprosthesis which are being used in India right now. So there are 9 examples, there are probably more. And in history and literature, there are more than 140 different types of keratoprosthesis which have been described and developed and tried in patients. So it's actually quite a diverse field. And in LBPI, the algorithm that we use to select cases, and I've alluded to this before, but I'm just going to say this again because it's very important, is that if you have a patient with unilateral corneal blindness because of say chemical injury and LSCP, then you will assess visual potential first. And if the patient has visual potential and has a wet surface, then you can try something like limbal stem cell transplantation, like select-like procedure along with keratoplasty if necessary. But if the patient has a dry surface or does not have visual potential, it's best, these are eyes which are best left alone. If the other eye is fine, then you don't want to intervene because these are not such predictable procedures. If you have a bilateral corneal blindness or the patient has, this is the only eye, then again you assess the visual potential, and there are different types of keratoprosthesis you use for different indications. So if it's a wet eye, then you use a Boston type 1 design. If it's a dry eye, then you have something like the OKP or the LVK. Now, even when you talk about Boston type 1, there are different variations, there are different types of designs, and these are the 3 commonly available designs that you can use. The Boston type 1, which you order from Sayan here in Boston, it costs about $6,000, and if you know them well, for developing countries like India, they sell it at a subsidized rate of $600. Whereas the Oro K-Pro, which is made in Oro Lab in Chennai, it is sold for about $100. It costs about 6,000 rupees. And it's much cheaper and anybody can order it. The Lucia is another form, but it's not commercially available right now. It's going to be much cheaper than the standard Boston K-Pro, but it's still being made. So this is essentially the surgical procedure. It's very simple, so anybody who knows how to do a keratoplasty can do a Boston type 1 keratoprosthesis. There are three parts to the keratoprosthesis. First, you punch the corneal button, you decide on the size and you punch it, and make a central 3 mm opening. You thread that tissue through the optical cylinder, and then you thread the back plate, which is the second part, and then you thread the locking ring. Now the Boston type 1 comes with a titanium locking ring which locks in, the titanium back plate it locks in directly and you don't have a separate locking ring. The Oro Capo, however, comes with these three parts. And once you have assembled it, then you do a cataract extraction or the lens extraction. Even if the patient does not have a cataract, the lens has to be taken out because it is not possible to do a cataract surgery once you put the keratoprosthesis in place. And then you suture it like a regular glove. So if you are thinking about doing a keratoprosthesis, the first ideal case would be if you are doing a chemical injury, it would be a patient that you have treated yourself, you know a patient who has some visual potential in doing it. Probably somebody with a wet ocular surface, no lid problems, a deep phonics where you put a contact lens, and who understands the risks that this is not a permanent fix, you need regular follow-up and additional surgeries may be required. So this is one of my cases that I operated in 2010. The patient is 20-30, had developed glaucoma, underwent AGV, and maintains 20-30 vision 6 years out. So these are some of the good cases that you can get, but it's about 50-50. Just to show you how the Oro Capo, which is available in India at a much cheaper rate, compares with the Boston Capo. This is our data about the same number of cases between 2010 and 2014, which shows that the survival of both these prostheses is more or less comparable in terms of anatomical survival, meaning how many capos had to be replaced or extruded versus how many remain in the eye. And even if you look at visual outcomes, they're very similar. So they perform pretty well. Dr. Namrata has published their series on the Oro Capo and BJO, which also says that they do pretty well. However, this is a procedure that is not free of complications. So these are the common complications, and you can add the numbers for the Boston and the Oro, and you'll find that for everything it's pretty much the same. Only this is one complication that was seen only in the Oro Capo, the locking ring dislocation. That happens because earlier when they were providing the Oro Capos, the assembly was not very easy, and it was slightly more difficult than assembling a Boston Capo, and this used to happen. Now they made it much better, and this doesn't happen. This happened only one case, but you have to make sure that you fit the locking ring carefully. Otherwise, you have about a 10% chance of endophthalmitis, which is much higher than in routine intraocular surgery. And keratitis is also fairly common, about 9-10%. And sterile melts can happen if the patient uses the contact lens or develops a dense RPE. The commonest complications, however, are retroprosthetic membrane, which is about 40% in Boston Capo and about 50% in Europe, which can be either removed by doing a YAG laser or you can go inside and do a membrane. So if you compare our results with those that have been published elsewhere in the world, particularly in the United States, they are very comparable. The outcomes are almost very similar. So it's not as if the Boston Capo does much worse in India. It's a developing country and there's a high risk of infection. There's nothing like that. The incidence of infection is almost as much as it is elsewhere. If you take good care, the risk is the same, but there is a greater risk than other intraocular procedures. So the Boston type 1 Capo is very, very good for bilateral disease, wet surface and scarred corneas like post-chemical injury LSCD. And patients who need visual rehabilitation. You would not want to do this procedure because of its risk in patients who are otherwise well adapted to their visual handicap. Okay, so multiple field grafts and LSCD post-ocular burns are the good indications for doing this procedure. Make sure the patient understands the risk, is comfortable with self-care. So whether you want to do such procedure in children is a question that you need to ask yourself when you think about it. I personally do it very reluctantly, and I've done it much less in children than in adults. And you want to avoid cases like autoimmune disorders in their case. How about if you have dry surface? This is much less common with chemical burns because you usually do not end up with surfaces like this, but you can. It's much more common with SJS. And in these, your options are very limited between what was traditionally your OKP or the Boston type 2. And we have done about 30 OKP procedures and also published the results, and they do very well. But they have a lot of complications, and the surgical technique is very complicated. So it's not something that everybody can do. Therefore, we moved away from the OKP over a period of time to find a simpler solution for these kind of complicated cases where you have dry surfaces. And the keratoprosthesis that we developed at LVP, which is called the LVP K2, is also manufactured by Orolab, is one where you do a mucous membrane flap to protect the surface, and you do the prosthesis in the same way as you do a normal Boston type 1. But if you look at the prosthesis, it's slightly raised from the surface. We will compare it to the normal Oro Capo so that it can be the optical cylinder can be exposed through the mucosal flap, and the flap can be tucked under. So these these are the outcomes, they're mostly for SGS patients, but they can also be done in patients with complicated chemical burns. And cosmetically, it looks a lot better than the OKP, which is a much more difficult option. And the initial visual outcomes are quite satisfying. The anatomical retention is pretty good. It's about 60% at 2 years, and we will be publishing these results soon. And we have a newer modification also of the device which Aurora is making, so that might have better outcomes than what we had previously. So you have to remember, when you're talking about keratoprosthesis, I think the philosophy is that it's not a permanent fix. You put in the keratoprosthesis in somebody's eye, it's not going to stay forever. And the longer the patient has the keratoprosthesis in the eye, the higher the chances that the keratoprosthesis is going to extrude. So you have to keep the patients on follow-up almost lifelong. And we of course need a better network of corneal surgeons to handle keto. Right now the problem that we face is that a lot of patients get referred to us for doing a keratoprosthesis, and we do it and send them back. The referring surgeons are often not competent enough to handle the problems, and therefore every time the patient has to come back to us for every little problem. And because the margin of error is smaller in keratoprosthesis, you sometimes end up with complications that are very difficult to manage. However, it is something that is evolving, and outcomes are much better than they were 10 years ago or 5 years ago. And I think that this is something that is holding a very good promise in future with better designs and hopefully better outcomes. So just before I finish, I want to thank all the people who have been involved in this journey. Vinay Pillai, Dr. Sangwan, Professor Falcinelli, Dr. Dorman, Josh from Boston, and also Dr. Acker. So thank you very much, and with this we conclude our IC. If you have any questions, we have to take. Otherwise, thank you very much.